Welcome, everybody. My name is Elizabeth Ekstrom. I'm from Oregon Health and Sciences University. I'm a geriatrician there and do a lot of work with teams from various places and various communities. And we are absolutely delighted to be here today, seeing your amazing facility and having the opportunity to share some things about falls preventions with your teams. So we're delighted you could all come. I'm going to quickly introduce all of our team members. You're going to see them all because everybody's going to do a little bit of the presentation today. So Margaret Neal, Director of the Institute on Aging at Portland State University. Cy Simonson, our School of Pharmacy from Oregon State University, faculty member. Yeah, we got an OSU bunch here. Glenise McKenzie is at the School of Nursing on the Southern Oregon University campus, but it's an OHSU nursing program as well. Vicki Cottrell is from the School of Social Work at Portland State University, and Kathy Lassiter is from the School of Nursing up on the Portland campus. So as you can see, we're a very interprofessional, our team has come together from all of these different professions and schools to try to work together on how to do good falls prevention via a team-based approach. A few comments about today. As I mentioned earlier, there are continuing education credits available for doctors, nurses, social workers, and pharmacists. If you're not one of those and we can't give you continuing education, we do apologize for that. In order to be eligible for your continuing education, you do need to complete the pre-tests and the post-tests, so basically the evaluation materials, and then just make sure you let us know that you want the continuing education so that we can follow up and take care of that for you. And Samantha is the person that was sitting at the back. She's the person that will be in charge of ensuring everybody gets their continuing education credits. Okay. Our project is funded through a grant from HRSA, the Health Services Research Administration, which is a tiny little branch of the federal government whose goal is to improve access to care for older adults and to improve the quality of care that older adults in the community receive. You guys are pretty much a role model for providing quality care to older adults in the community. So we're learning from you, and we're enjoying seeing this amazing place. But hopefully this is something that your teams can be part of as well in really figuring out how to systematize ways to prevent falls in all of the different levels of care that you guys have. After the workshop is over, we will be studying outcomes from this workshop. So you are now all part of a research project, which is why we've asked you to sign the consent form. And we would like to follow up with you from time to time over the next 12 months. And then at the end of the 12 months, we'll be sending some of our research team back to look at some chart reviews and look at some care plans and see whether there is documentation of falls risk, see whether there has been an increase in vitamin D prescriptions or things like that, all of the components of this intervention. So we'll be trying to set up with you approaches to kind of, get to 100% on all of those things and have really good systematic processes. And then we'll be coming back to see how it did. And a lot of our teams really love this part of the project. We've had a number of teams who were already pretty good. Maybe they were at 60 or 70 or 75% in documenting things like, giving out vitamin D supplementations, doing home safety evaluations in people who need it, things like that. After our project, they figured out a process to actually get all the way to 100%. So turn this into something that everybody gets in a very systematic way. And that really is the goal for this culture change, to ensure that things are happening 100% of the time. All right. Yes, Kathy. Oh, prizes at the end. I forgot to mention the prizes. And just as an added incentive for everybody who does complete both your pre-intervention paperwork and your post-intervention paperwork, because we do know it's a pain to do it, we have some Geriatrics at Your Fingertips books, which are this just a lovely reference guide for care of older adults, and you will get one of those as you walk out the door if you've completed your evaluation materials. Thank you, Kathy. Now, I would love to go around and hear all your names right now, but we don't quite have time for that, and I'm hoping we'll get to know you better as we break into teams. But I do want you to feel like this is a very informal discussion. You may interrupt with questions, comments, suggestions along the way. We are not here to just speak at you. We're here to engage in a conversation with you to really kind of see what could be improved for falls prevention in the communities here. So please, hands up, yell, whatever you want to do, just have ask a question or comment or add something in along the way. And we will be stopping for questions along the way as well. All right? Any questions right off the bat? Okay. All right. Well, I've already introduced you to our team. Samantha is also with us here. She's our support person. And then I wanted to recognize Melissa Bosworth, who's been with the project for the last 5 years but left recently and helped a lot with support for this work. So, what are the goals of the project? Well, the goals of the project is to reduce the rate of falls. And I'm guessing the top of this hill is not like the rest of your area, but you may know that the Southern Oregon counties, Jackson County, Josephine County, have the highest falls rate in the entire state of Oregon. So you guys are in the midst of a falling epidemic. And so it's particularly important, and falls are still a very important medical problem for older adults. So really, we're here to really think together about how to best prevent falls and to think about how to ensure that across all settings, everyone over 75 gets screened regularly for falls. If somebody screens positive as being at risk for falls, or if somebody's had a fall, they have a systematic falls risk reduction program implementation. And then hopefully it will be something that gets incorporated into day-to-day life so that that practice is maintained over time and that all older adults in the community can have a higher quality of life. Now, as we do all of this, it's also really important to make it fun. So nothing happens if you don't enjoy it, if you don't have fun with it, and hopefully we'll be able to have some fun today. Okay, here's the first interactive part of the session. Margaret wants to, are you going to collect those? Okay, and Margaret's going to come around and collect your paperwork. So as she comes by, go ahead and hand off your paperwork to Margaret and to Samantha here. All right, what's the right answer to this question? Shout it out. All of the above. Excellent. So these are pretty impressive statistics, aren't they? 20 to 30% suffer moderate to severe injuries, 4 to 5 times more likely to be admitted to a nursing home after a fall. Pretty impressive. What's the answer to this one? Again, it's all of the above. Good, you are absolutely right. So again, some frightening statistics about how our older adults are struggling to maintain their independence. Okay, how about this one? You can see whether I'm a broken record. What's the right answer here? None of the above. Excellent. Right on. So, and I think maybe the doctors are the worst offenders in this realm because we tend to tell our patients, just get out and walk, right? We say, take a walk, take a 20 to 30 minute walk every day. But guess what? Walking doesn't reduce your risk of falls. Walking is good for you for other reasons. It protects, it has cardiovascular benefits. It protects you from all sorts of good things. But it does not improve balance, and it does not prevent falls. So having just a walking program is not adequate for falls prevention in older adults. All right, so the right answer here is none of the above. Okay, so again, this really adds up. 8% of the population greater than 70 visits an ER for a fall. Isn't that amazing? That's a lot of people. A third of these require hospitalization. And then, there's just a lot of information here about costs, which are currently skyrocketing. One of the most important things from my perspective is this one right here. And I've learned so much from my social workers on the team about this, because a lot of times we don't think about fear of falling, either after somebody's fallen or even before they've had a fall. They might be afraid they're going to fall. And guess what? The worst possible thing you can do when you're falling, reduce your activity, right? That's when you actually need to increase your activity, which is why we have people like Dean here today, right? I got your name, did I get your name right? Okay. So 42% of fallers reduce their activity, and that's a very important statistic for us to be aware of. And then, of course, it can precipitate entry into long-term care. Well, what is a fall? So I kind of like this slide because, we think of a fall as when you fall on the ground, trip over a curb, whatever. But actually, falls are anything where you come to rest on a lower level that was unintended. You did not intend to be on that lower level. Now, when I go skiing, I expect to fall. In fact, I fall about every 5 minutes when I go skiing. And if I had to report my falls, I'm not sure I'd count those because I did kind of intend to get down to a lower level. But most of the time, it doesn't have to be onto the ground. It can just be against the wall, into a chair. Those actually count as falls. And there are all sorts of ways to describe falls. And our residents will describe them in many different ways. So this is a little bit older slide. I left it up because it's got one of my favorite things on it, which is a drop attack. I'm actually old enough to remember when drop attacks were part of the medical lexicon. I don't know if anybody else here is, but you just kind of fell over and you weren't quite sure why. With orthostatic hypotension or some other thing. But as you can see, about a third of all falls are for environmental reasons. And probably in a community like this, you have lots of things around the facility to help reduce the risk of falls. You have grab bars up in needed places, you don't have loose rugs, a lot of things are kind of done already to make sure that environmental risk factors are limited as much as possible, but it's a very important thing. And then the list is long of other reasons why people might fall. And then fear of falling. I talked a little bit about this already, but I wanted to show you some of the evidence around the importance about screening for fear of falls. It's a strong, independent predictor of future falls, and really the major predictor of activity avoidance for older adults. That is the main reason people reduce their activity, is because they're afraid they're going to fall. It's also the strongest predictor for outcomes of rehabilitation. So if you're seeing somebody in rehab, or you've got a resident who's going to rehab, and they're afraid of falls, it's the strongest predictor for how well or poorly they're going to do with that rehab outcome. So fear of falling is an incredibly important thing to address at every step along the way. A lot of people either underestimate or overestimate their fear or their risk of falling. It can be bad either way. I've got, a couple people in my practice who say, oh, I'll never fall. And next thing you know, they've got 3 broken ribs from falling down the stairs. And in long-term care facilities, this is a really interesting one. Caregiver fear that a resident might experience a fall predicts the use of restraints and activity restrictions. So if the caregiver believes that patient is at risk of falling, the caregiver will make them less active, will allow for less activity, will encourage less activity. And it's kind of the last thing we want in most of our settings. So this is hot in the news. If anyone hasn't seen this column, go to the web and look at it. It is so cute. My 84-year-old father-in-law is a flogger. That's the moniker his son gave him because Dad keeps a written record of every fall my 83-year-old mother-in-law takes. So a blogger on falls. Anyway, but it's just a great recent scenario of why falls is so important in our culture. So do all of your units systematically screen people for falls here at the Rogue Valley Manor? Do you guys do a systematic screening for falls? I'll bet you do in the SNF because you have to do the MDS, right? Do we have any SNF people here? Of course. Any of the other places have a systematic way? How about the clinic? Do you guys do some screening, kind of systematic screening for falls in the clinic? Yeah, and okay, great. And so this is proven, well proven in research, and the U.S. Preventive Services Task Force, which is the governmental body that recommends screening, does recommend yearly screening for all older adults greater than 75, and the number needed to screen to prevent one fall is only 20. So for every 20 older adults that you screen for falls and intervene if they're at risk of falls, you will prevent one injurious fall. That's huge. That's really good. I mean, you know, mammograms, we all think everybody needs a mammogram, right? But the number needed to screen for a mammogram for women aged 50 to 69 is 400. So 20 is way better than that, isn't it? You only have to screen 20 people. As I've put up here, you might be familiar with the timed up and go. So who knows how to do a timed up and go test? Who wants to be our demonstrator? You don't get to, Dean. Unless nobody else can. Anyone else know how to do a timed up and go? No? Okay, well then let's Dean do it then.
Yeah, I've got everybody here. I'm the only volunteer.
Let's see. Whoop, whoop. I'm going to pull the whole table here. Okay, how do you do a timed up and go?
So start in the chair. Yeah, we get up.
Good.
Walk 10 feet. Turn around. Get back.
You are perfect. And did you see how he did that without using his arms? That's what you really want to see. And I have all these little old ladies, they're sitting in their chair. I say, don't use your arms. So what do? They kind of crook their elbows on their knees, right? Or they kind of sneak that arm back to the side. Thanks, Dean, that was perfect. They sneak their arm back to the side. So you really want to have them get their arms up in the air and not use their arms at all. And you know, if you do have to use your arms, if it takes more than 15 seconds to perform that test, those things are very strong indicators that you're at increased risk of falling. And it only takes 15 seconds, doesn't it? It takes longer in some people who can't do it very well. Yeah, Dean.
Last year, we actually did some timed up and go tests it was just a voluntary sign up.
Yeah.
We had about 6 different, everything from balance tests to strength tests. And all our balance tests were just static balance tests. But what we did is for independent people who wanted to try, we had them go through a series of tests, and then we put them on some sort of balance exercise program. Either had them joining our balance class, had them joining our core class.
Perfect.
Everything. And then we retested 8 months later so people could compare and see how much they had improved.
Did they show improvements?
Most of them did. Yeah.
Wow.
The ones who didn't were the ones that we didn't see in class.
Right. Okay, so I got to actually do the work to get the benefit, huh? Great, that's fabulous. And hopefully that will continue and have those kinds of assessments for them and availability. Excellent. Okay, and then of course for the people at the skilled unit, the MDS has a falls screener in it, which everybody has to do. All right, so if somebody screens positive for a fall, either they report to you that they've fallen in the last 12 months, or when you do the get up and go test, it's positive. It takes them longer than 15 seconds. Then you want to do further assessment. And these assessments are all evidence-based from good research studies showing that if people do these interventions, the risk of falls will go down, okay? So these are basically what we're going to talk about today. Further assessment of gait, checking for orthostatic hypotension, other cardiac problems, exercise programs to prevent falls, and Tai Chi actually has the strongest data behind it, so we'll talk a little bit about that. And the tool called motivational interviewing is a communication skills tool that can help us all be better counselors and coaches and cheerleaders to help the people that we work with reduce their risk of falls through exercise. Are people familiar with that concept, motivational interviewing? Is that familiar at all? Not too much? Okay, we're gonna have a session on that during our workshop this afternoon, so that'll be good. It's really effective. Vitamin D and calcium supplementation, reduction of risky medications, as well as total medications. And the research shows that people who take just more than 4 pills a day have increased risk of falls. Now, how many of our older adults don't take more than 4 pills per day, right? But as providers and as team members, part of our job is to be kind of constantly reassessing and saying, okay, do we need to try to reduce some pills? Are there things this patient doesn't need anymore that might make them safer from a falls perspective? And then environmental modification. And we're going to show you some of the data about how important these environmental things are. All right, and this is the reduction in falls that comes from each of these things I suggested. So again, I mentioned that Tai Chi is really good. It basically cuts your risk of falls in half. And I'll show you one of the studies that I was actually lucky enough to be part of around Tai Chi. Now, if we say, well, I don't want to do Tai Chi, I want to do something else. You know, you can do other strengthening and balance classes. Interestingly, look at this. They had 17% reduced risk of falls. So 49% reduced risk compared to 17%. You're going to get a lot better benefit from your Tai Chi, aren't you? Vitamin D supplementation showed a 26% reduction. Here's the biggest bang for your buck from a medication perspective. Those psychotropic meds, the antipsychotic medications, the benzodiazepine, the sleeping medications, all of those things are very important, and we'll talk a little bit more about that. And then home safety assessments for people with a history of falls had a 34% reduced risk. So again, pretty powerful risk reduction with some of these interventions. And then if you want to kind of think from a societal perspective and a preventive care perspective and think about the cost of these interventions and how helpful they are, I've highlighted the two that, again, came out to have the best cost effectiveness for preventing falls. And again, group Tai Chi and vitamin D were the ones that are both some of the most effective, but also some of the most cost effective. So those are really great and important things that people can do. All right, so here's one of our Tai Chi studies that we did right here in Oregon. I don't know if anyone from Southern Oregon was involved, but we did a 6-month randomized controlled trial of Tai Chi 3 days a week versus a stretching control. So people would sit in a chair and just do chair stretches. That was our control group because we figured that would not help their balance. And after 6 months, in the Tai Chi group, only 38% of the people had had a fall, and in the stretch group, 73%. So a dramatic reduction in falls. And look at the injurious falls rate I've highlighted. These are falls with injury, need to go to an emergency room, need to be seen in the hospital, things like that. And again, the falls were reduced by about half in the people who took Tai Chi. It was 3 days a week. I know you guys have classes 2 days a week, but you also have yoga classes on the other 2 days. So I'm going to guess you're probably getting the right dose, and having that be available. And then just to show you a little more data on some of the other exercise. So these were big randomized controlled trials in a number of studies across the U.S. with a variety of interventions, strength training, balance training, things that were just not Tai Chi. And these people had greater than 2-year follow-up. And again, with this huge number of people and quite impressive trainings, there was a 17% risk reduction via these other modalities. So it's not that they don't work. People can lift weights or do the stretchy bands or do other things at the gym, do other things in physical therapy, but the risk reduction is not quite the same as doing some of the movement classes. All right, so now's your chance. Actually, I would like everybody to stand up because we are now going to try some Tai Chi. All right, so you might want to push your chairs in to get a little bit of space behind them. And if you want to come out into the aisles, that's okay. And spread around a little bit. All right, and we're going to give it a try. So Samantha's ready with the volume over there. Let's see.
Hi, I'm Alex Nelson. This is my good friend Jacob Evan. We're with Oregon State University's Health and Human Science Department, and today we're going to be talking about the benefits of Tai Chi.
Before we begin, I would like everyone to go ahead and clap along with us. With each clap, somebody in America experienced a fall. There are 30 million falls annually in America. This averages out to be 1 fall per second. For most older adults who suffer from a fall, life is never the same.
Studies have shown that half of vertebral fractures are the result of a fall, and 95% of hip fractures also come from a fall. The most effective way to reduce one's risk of fracture is to just stop falling. What does that mean? That means improving balance, strength, and neuromuscular coordination.
This graph shows the outcomes of older individuals 1 year after they have suffered a hip fracture.
As you can see, 20% of the individuals die within the year. A quarter of the individuals enter long-term care. 40% of those who have suffered a hip fracture are unable to walk independently, and 60% are unable to perform activities of daily living.
Many of these falls can be prevented through an exercise and balance program. Today we're here to introduce a Tai Chi program that increases strength, improves balance, and decreases the occurrence of falls in older adults.
Our Tai Chi program is great because it combines many movements into one routine that's slow and gentle on your joints. Also, studies have shown that Tai Chi, more than any other exercise, improves postural stability. Also, Tai Chi can be done alone, in a group setting, and without any equipment necessary. Anyone can do it anywhere.
Without further ado, here's your instructor, Master Nguyen.
Hi, my name is Anthony Nguyen, and I'll be your Tai Chi instructor today. My first lesson will teach you how to stand properly to maintain proper balance and posture. First, have your feet shoulder width apart, knees slightly bent, and make sure you have a center of balance between your toes and your heels. Next, have your hips rolled forward and your shoulders relaxed. That way, from top to bottom, head, shoulders, knees, and ankles are stacked on one another. That way you can have proper balance and maintain that base to perform these Tai Chi movements. Next, take a deep breath and exhale. Tai Chi is made up of coordinating movements and breathing at the same time. For instance, if you were to move your arm up, you would inhale. Once you reach the top of your movement, exhale. Next, to perform a proper Tai Chi movement, you want to make sure that you're unbalanced. And a lot of these movements incorporate weight shifting. So first, you want to slowly shift your weight to the left side. And shift back. Shift your weight to the right side. And shift back. Now don't rush on these, because the slower you do it, the more time you can think about what your body's doing, how your body's going to react, and how safe you can perform these movements. Tai Chi movements like to incorporate daily activities in the lives of the olden days, like the fruit grab. Take your right hand, inhale, reach the top, exhale. And you drop into the basket. Take your left hand and do the same thing. Inhale. Exhale. Our next exercise is the rice planting stretch. You want to take a deep breath in and roll your head, leading with the chin. As of each vertebrae, we're slowly rolling over one after the other. Come back up. Our next stretch is the circle stretch. You're going to take your right arm and move it up in a circular motion, as so. Breathe in and out. Breathe in and out. Breathe in and out. In and out. Both hands now. You can view two hands on one side. Our next stretch is the back stretch. The key to this stretch is not to move your legs. So you want to pretend you have a melon or a ball in your hand and slowly rotate. And to the other side.
So that tape was made by some of the graduate students at Oregon State University, and in each of the boxes there is one of these videos. It's actually a little bit longer, so that if there are other staff members who aren't able to come today and they want to get a glimpse of, how Tai Chi can work for older people, you can have them view the videotape as well. How did that feel? Feels good, doesn't it? Tai Chi is amazing. It improves your core strength. It gets you standing up better and straighter. And, for a lot of older people and a lot of people in my practice, they say, there's no way I could possibly do this. I'm way too frail. I'll immediately fall. It's too hard, right? What do you tell them if they don't feel they can do some of this stuff right off the bat? Say it again? You can work up to it? Absolutely. What would be an easier way for them to start? Anyone? Sitting in a chair, good. Yeah, so chair Tai Chi is a great way to start. And I think some of our videos do have some chair Tai Chi for you as well. So if you're in one of the communities where people are a little bit more frail and you'd like to introduce some Tai Chi, using the chair Tai Chi could be very helpful for them, because you don't have to go to a class. I mean, I know Dean's got classes, but there might be people for whom that class isn't the right thing. And starting doing some chair work in a smaller group can be a great way to start. And then once you've progressed a little bit, you can stand up, but keep your chair there. Because if you need to hold on to the chair for support, or if you can't make the whole class and you have to sit back down, you've got the chair readily available. Okay. All right. Now I'm going to pass the podium over to Sai, who's going to talk a little bit more about medications. And you've got the handheld mic. I'm turning me off. Here's this, and you can turn you on. Are you on?
Nobody turns you off. You're the Energizer Bunny. We had a tour today. Erica took us on a tour, and our socks are collectively knocked off. It's an unbelievable facility. You know that, but it's really, really fun to see it. Also very nice to see Fred. I have not seen Fred in probably 30 years. I was a professor at Oregon State when he graduated. I was 15. But it's good to see him. He still looks the same. And it's good to see that there's some Beaver influence here. Deans in Oregon State are obviously, and there's probably, a couple others. There's a preponderance of duck influence here, I've noticed. We've been here for a couple of days and spent some time in Ashland, and there are a lot of the orange or the yellow O's, including these poor little children who know not what to do, so they're being raised like, but anyway, it was, okay. It was only kidding. I like the ducks, but we also saw the play Two Trains Running. That was great. So anyway, I've got about 12 slides. Elizabeth mentioned vitamin D as an intervention that can reduce falls and reducing unnecessary medications. So it's a pretty simple concept, and I'll go through it. Very interesting thing about vitamin D. We know that vitamin D and calcium are taken in combination to strengthen bones and decrease fractures. That's not really the primary role of vitamin D in fall prevention. Vitamin D is involved with RNA protein synthesis, and synthesizing protein helps you develop muscle, which makes you stronger, And the stronger you are, the less likely you'll fall. If you can maintain your balance, you won't fall. So within a few months of vitamin D supplementation in someone who is insufficient, you can see a statistically and clinically significant reduction in falls. And it's good news because it's cheap, it's easy. What's to hate about vitamin D? Daily doses of at least 800 units are needed to observe the benefits. A number of studies have shown pretty good response within a few months, but you need at least 800 units. You give 200, 300, that's not enough. Calcium is also used. Calcium's a different subject, but I wanted to mention it. Calcium is needed for bone strength. There's controversy now. There's been a couple of studies that indicated, well, maybe calcium supplementation might actually increase cardiovascular risk. And the data is still out. It's not overwhelming. There's some indication, maybe there's an association. And if there is, the mechanism is probably that calcium is 99% bound to bone and teeth. And if you give an excess amount in supplementation, you might have hypercalcemia in the bloodstream, and calcium is very much involved with cardiac conduction. Certainly not enough evidence to say decrease or stop calcium administration. Although if you can supplement calcium by diet, probably better than giving medications. So diet's always the best way. Vitamin D3 versus vitamin D2. I'm going to talk about the differences, and I'm going to give you a real easy way to remember which is the preferred vitamin, because I always got confused. Vitamin D2, D3. Vitamin D2 is ergocalciferol. It is plant-derived. It's not commonly found in food, so it's kind of hard to get. It's less bioactive than vitamin D3. It's less stable. Its half-life is shorter. It's less potent than D3. So it does appear, based on what I have here, that there are some disadvantages of D2. D3 is cholecalciferol. It is produced from sun exposure, which is usually pretty limited in seniors, and maybe unless you're out there playing bocce ball or something, that's the way to get vitamin D. And if you wear sunscreen, vitamin D production in the skin is remarkably decreased. But D3 is the preferred form of vitamin D. The affinity to receptors is greater than vitamin D2. The 15,000 units of D3 is equal to 50,000 of D2, so it's more potent. And basically, the way to remember it is chole is cool, or bigger is better. 3 is bigger than 2, so bigger is better. And that's so if you have a situation where you have D2 and D3, you go, oh, that pharmacy guy, 3 is bigger than 2. Okay, cholecalciferol. Now, that being said, it's still okay to give vitamin D2, and I'll give you some examples. One of the things that we do now that we're paying attention to vitamin D is measuring vitamin D levels. And Elizabeth might want to comment on this later, but we know that less than 20 nanograms per ml is considered deficient. 20 to 30 is insufficient. And really levels of greater than 30 nanograms per ml are the target. And I've talked to some clinicians that say 50, 60, 70 might even be better. But that's what we go by for the range of vitamin D. There are various dosing protocols, often a loading dose. If somebody's found with a vitamin D level of 5 or 10 nanograms per ml, which is not uncommon in any state, but especially Oregon, where the sunshine is not always predominant. A loading dose of, let's say, 50,000 units by mouth weekly for 6 or 8 weeks. And then in that case, vitamin D2 can be used. It's a prescription vitamin D2 product of 50,000 units. Then when they get supplemented, then going down to a maintenance dose of 1,000 to 2,000 international units of vitamin D3 every day. And Fred does, I believe, have that in the pharmacy. So it's inexpensive, it's easy to get. The toxicity is very low. There have been a couple of case studies of inadvertent vitamin D toxicity where someone took a number of doses of 100,000 IUs and no consequences, really. I mean, they took them for a couple of weeks and a couple of months. So it's really hard to have any problems, unless hyperparathyroidism exists, which is pretty uncommon. So D3 is pretty safe, pretty effective, and inexpensive, and it works. So then my second topic here, the other pretty easy intervention, although it's a little more complicated, is let's look at high-risk medication. There's a lot of medications that can contribute to falls, as Elizabeth mentioned. Certainly the psychoactive medications, the antipsychotics, the anti-anxiety agents, the sedative hypnotics, antidepressants, they can all contribute to falls. Pain medications certainly can. Anti-Parkinson's drugs, anti-epileptics, anticholinergics, cardiovascular drugs. These categories can commonly contribute to falls, but especially so if the drugs aren't used correctly. At proper doses and with proper combinations, you can modify the therapies to make them less likely to cause falls, but still give the patient, the resident, the advantage of these drugs. I'm not an anti-drug pharmacist. I'm an anti-inappropriate use of drugs pharmacist. And another example, sliding scale insulin. That's we don't consider that a psychoactive drug, but that's a combination. That's a therapy that can result in more falls, and it's not highly recommended. So those are just some examples. Now, let me talk a little bit about reducing inappropriate medications. In nursing homes, there are regulations that require a gradual dose reduction, GDR, of antipsychotic or psychoactive medications, including antipsychotics and anti-anxiety agents and sedative hypnotics. And one of my mantras in geriatric pharmacy and geriatric medicine, it's a lot easier to start a drug than it is to stop a drug. And you start a drug and Mrs. Jones doing okay, she's not falling, she's not sleeping, and you say, well, okay, everything's stable, let's not rock the boat. You know, it's easy to kind of get into that mentality. It's everything's stable, let's not rock the boat. Well, what's a good example of a drug that is nationally way overused, because when someone's on it, it's not causing any problems, it's not causing any toxicity, it's not super expensive, and we have no incentive to take them off the drug? Proton pump inhibitors. We have people on proton pump inhibitors for GI acid for years. And that's, you know, there's no toxicity. When PPIs first came out, we just basically figured zero toxicity, so no reason to stop, even though the indication might only be for 4 weeks. But yet you see people, because we don't ask the question, should we continue this drug? And that can result in polypharmacy. So the message here is that the need for continuing a drug should always be a question. That should always be when we're reviewing therapies, whether it's nursing or pharmacy or whomever. Just always consider the question, do we still need this drug? Because a lot of drugs have an indication that goes away and we no longer need it. So the gradual dose reduction, or the GDR, can be attempted to reduce medications, but we do it gradually because a number of medications, especially the psychoactive drugs, that can be a withdrawal phenomenon if it's abruptly stopped. The benzodiazepines, some people have been on benzodiazepines, maybe anti-anxiety drugs or sleepers for years, and you don't want to go cold turkey because there'll be physical symptoms of withdrawal. Gradual dose reduction is required in nursing facilities, but the principle can be applied in any care environment, anywhere medications are used. GDR requires the cooperation of the entire team. It can't just be one person, and it may have very positive benefits. And I'm just going to conclude by showing you a slide or two on a GDR study that was published. It involved a prospective 6-month clinical trial in a 150-bed nursing facility, skilled nursing facility. The selection criteria were patients were taking psychoactive medications, they were exhibiting disruptive behavior, and they had pressure ulcers and or falls. So it was a kind of a high-risk study group. There was an interdisciplinary team consisting of a nurse, a social worker, a dietitian, a consultant pharmacist, and therapy and activity staff. So pretty comprehensive team. Who is missing from the team? The physician. This doesn't mean that physician didn't have input, because the team would meet, They had bi-monthly meetings, a monthly chart review, twice weekly team meetings. And then the team's recommendations were given to the physician who had the ultimate decision. The way they ran this study, they didn't have the physician involved in the actual meetings, but he or she was certainly would agree with or not the final recommendations. Here's some selected results. Hypnotic drug use was decreased. We'd expect that because that was what the study was all about. Anxiolytic and antipsychotic drugs were decreased. Psychiatric discharge to hospitals because of probably behavior issues decreased by 72%. Pressure ulcers decreased by 66%. Decline in ADLs decreased by 59%. Untreated depression decreased because we're using more antidepressants. Falls, highest risk falls, down by 25%. Falls resulting in hospitalization down by 23%. Fractures by 17%. How many think that that's not positive outcome? I mean, what's not to like about GDR? This required a team approach. It required resources. It required finances. But I think if you did a financial analysis, it's probably a pretty good bottom line here. If nothing else, but stability of the residents not going to hospitals for falls or other problems. So how to make a GDR work, and this is what we'll be talking about when we meet with the teams. Any environment, whether it's a nursing facility, which is my team, or any other environment, you need support of the medical director or administration. They have to be on board with this concept. You certainly need the attending physician, nurse practitioner buy-in, because they're the ones that are going to be writing the prescriptions, and they're the ones that get the calls at 3 in the morning. And, you know, of course, you're there at 3 in the morning too. You need cooperation of the entire team, as we do with anything involving senior care. But you need the team cooperating. Certainly, records have to be kept. The GDRs can be scheduled in advance. You can plan ahead. If somebody's been on a drug for a month or 2 or 3, and then maybe schedule a time for the review. The pharmacist has an important role in coordinating and documenting the GDRs. The potential for embracing positive outcomes is a real one, and GDR can be adapted to any care environment. So it's a concept we'll be talking about. This doesn't mean, us talking about GDR doesn't mean you're not doing it already. Of course you're reviewing medications. But there's always a little room to kind of raise the bar a little bit and try to get the medications that might be contributing to falls to be reduced or minimized. Thanks. Elizabeth.
Good afternoon. So what I want to talk with you about is what we can do in residents' homes in order to make them safer, to avoid falls, to prevent falls. So I talked about reducing medications, gradual reduction of medications, taking people off some meds entirely. Elizabeth talked, and using vitamin D as a way to decrease the risk of falls, but I'm talking about environmental approaches to reducing falls. And we're going to talk about footwear, we're going to talk about eyewear, so vision, home hazards, and then fear of falling. So in terms of footwear, this is not something that we think a lot about in terms of preventing falls. But there have been a number of studies that show that the kinds of shoes that we wear really make a difference in terms of our likelihood of falling. And one large prospective longitudinal study showed that footwear really does matter. And the safest kinds of shoes are athletic shoes or canvas shoes. And those are shoes that either tie or they have the kind of drawstring to keep them on your foot. What you don't want are shoes that you can walk out of easily. Slippers are terrible. Clogs are not always all that good, especially for older adults. And going barefoot, which seems like it might be a good solution, actually increased falls tenfold, so by 1,000%. So going barefoot is not a good solution. Oh, the 5-finger shoes. Well, if they stay on the feet. Oh, okay. So I'm sorry. The question was, what are your feelings on the 5-fingered, 5-toed shoes? Right. So if they have good support and they're stable and arch support, and they're not going to push you too far forward or too far backward, and they stay on your feet so that you can't walk out of them, they're probably okay. Would you agree, Elizabeth? That's my concern.
I worry a little bit about those as well too, because they don't tend to have as much foot support, and sometimes
Stability.
they don't have backs. You know, having a heel or a back to the foot can often be really valuable. I don't recommend those for any of the patients in my practice. I tell them that if they feel good when they've got them on, but they're not really helping to reduce their risk of falls.
Usually because of that stability issue. Let me give you the microphone.
You should just keep that because you'll have lots of questions.
So I'd like to thank you all for coming to our presentation. So my other question that I have is, now what about like balance training barefoot versus shoes? Because you said shoes, being barefoot, being barefoot increases falls tenfold, but like balance training with shoes, you don't activate all the muscles in your foot as much as you do when you do balance training barefoot. So that was my other question.
Do you want to try or should I? Okay, so there's not a lot of research out about this, so it's not like we could tell you there were randomized trials telling of what it is, but for people who are in a structured Tai Chi program or a structured yoga program, where they're either doing it under supervision, they have a teacher, a trainer, a physical therapist, somebody like you, or if they've already learned the moves well enough that their risk of falling is low, that's probably okay. And the reason it's a little different is because they're now in that structured environment. They've got somebody who's making sure they're doing it correctly. They're not tripping over something on the ground or, doing things that put them at higher risk. So I actually do tell people that it's fine to be barefoot. Don't do it stocking foot. Don't wear socks and don't wear slippers. You're going to fall and die. And I tell my patients that every day. You're going to fall and die. I had an 89-year-old just like a week ago who I've preached and preached and preached about wearing shoes in the house. And guess what? He was walking down the stairs in stocking feet and fell and broke 3 ribs. Different guy from the last one I told you about. But if they're in that structured activity, then it probably is safe and okay.
Yeah, I just know a lot of our residents who take Tai Chi either buy those thin canvas Tai Chi shoes, or they will actually do the Tai Chi class barefoot. So, okay.
Well, they're not moving around a great deal either. They're
Yeah.
fairly rooted to the ground. So the difficulty is when you're doing a lot of walking around.
Okay, I just saw the 1,000% up there, and yeah, that's why I'm like, I hope we're not encouraging falls here instead of. All right, thank you.
So then in terms of thinking about vision, another study, large study, has shown that particularly for people who are very active, the use of progressive lenses, like mine here, where you can see distance up above and in the middle, you're sort of transitioning, and then down below is the close-up. Those actually increase the risk of falling by quite a lot. Now, how many of you in this room have progressive lenses in your glasses? Have you ever noticed that it can be really a challenge to walk down steps because you're trying to change? Your eyes are changing, the focal point is changing. And so that's exactly what's going on with these kinds of lenses. They increase the risk of falls for people who are active. Now, for people in the skilled nursing facility who are not active, then your single lenses actually increase the falls. So, and that's probably because the single lenses are either for distance or for close up, and so you're not having, you may be moving too quickly, and so if you've got your close-up lenses on and you're moving across the room, you're not seeing well enough to do that movement. In terms of evaluating our homes for hazards, what we want to do is look for uneven or slippery surfaces. Bathroom floors are a primary cause of falls when they're slippery. If somebody's gotten out of the shower and the floor is wet, or if they've had an accident, they're incontinent, and that floor is wet. Huge increase in falls that way. Using throw rugs or mats can contribute to a much higher risk of falling. Having poor lighting, so either lighting that's not bright enough, so the lighting is too low, the levels are too low. Also, having a lot of individual lamps, those are spotlights basically, and they can cause our eyes to look at that bright light. It's kind of like when you're driving and you see those headlights coming at you. That's what happens in a home that is lit only by those kinds of lights, where the lighting is very uneven. And so that can cause falls. If you have items that are difficult to reach, you say you're in a kitchen and you've got things up above, that can contribute to the risk of falling, because you're trying to reach up and maybe you're not really stable, and so you're not getting, you're not able to access those materials. Or worse, you're standing on a little step stool, and if your balance isn't good, you may fall off that stool. Electrical cords that are long, lots of times in older homes in particular, we see not very many electrical outlets, and so people have cords strung all over their houses. Now you'll notice that our videography team here has been very careful with their cords, and they've taped down all of the cords, so they have increased our safety in this room. Another cause of falls are chairs that are too low and they don't have arms. These chairs are great. These are really good chairs from a height standpoint for most of us. I mean, if we're very tall, they would still be too low. But they have arms. They're not very cushy. But a lot of times you'll go into doctor's offices or you'll go into people's homes and they'll have the overstuffed chairs sink very low into them, and then the older adult can't raise themselves out of that chair. So that causes accidents. So this slide, what can we do to increase safety in the home? We can be sure that we mark the edges of stairs, mark any uneven surfaces, such as the change from one room to another. Using yellow tape, as long as it sticks very well, is a good way to mark it. Making sure that we secure throw rugs, or best get rid of them if we possibly can, because they're just such a huge tripping hazard. We have chairs and toilets at appropriate height. We know that there are all sorts of things that we can buy for bathrooms to increase safety in the bathroom, like raised toilet seats, poles to help people get up. I can't remember the name of those poles, those long poles that you can move in the rooms, and they're affixed to the ceiling and to the floor. Thank you, yes, transfer poles, yes. We can arrange furniture so it provides assistance and doesn't get in the way. How many of you have seen people get around their apartments by going from one chair to the next? And it seems like a bad idea. If the furniture is stable, that's fine, as long as they're not going to trip on it. So you can arrange furniture to help, or you can clear it out of the way so that people have a clear path. Depending on the individual is which approach you're going to want to take. Making sure there are night lights. Again, not too bright though, so that they create a spotlight and then cause people's eyes to have difficulty focusing and then likely trip. Putting non-slip pads in the showers and in the tub. Putting grab bars in, everyone knows that, next to the toilet and also next in the shower. Having handrails along staircases. And again, looking at the lighting and making sure it's even and non-glare. And Elizabeth already talked with us about fear of falling and what a huge risk that is for people of falling, because if they're afraid that they're going to fall, they're going to limit their activity. They're going to be afraid to move around, thinking, oh no, I'm going to fall. And then what we find out is that they become deconditioned and they're much more likely to fall at that point. So simply talking with people about whether they're afraid of falling helps raise awareness, helps you as a provider understand what they are thinking, what their fears are, and then you can work together on creating a plan for reducing that fear. And one large study found that in fact, by talking about fear of falling, they were able to actually decrease residents' fear of falling, They helped people increase the amount of daily activity that they were engaging in. You can talk with people about what their fears are of falling and actually decrease the negative perceived consequences of falling. If people learn how to fall, then there are some techniques that you can use so that you don't hurt yourself as badly, and so then the perceived consequences of falling are reduced. And there were a lot fewer fallers overall after 14 months. So reducing fear of falling has a huge impact on actual reducing of risk of falls. And then both the American Geriatric Society and the British Geriatric Society came up with clinical guidelines for preventing falls. And their suggestion is that everyone over the age of 75 be screened for falls, and we're going to give you some techniques to use for doing that. That people engage in exercise that improves their balance and their gait and their strength. And Tai Chi, of course, has been highly recommended as an exercise for that. Supplementation with vitamin D, we've already talked about that. Reducing risky medications as well as total medications. Doing these things that we've just been talking about in terms of environmental adaptation to reduce falls risk. And then paying attention to raising low blood pressure and managing heart rate and rhythm abnormalities. So all of those are the clinical guidelines for reducing falls. Questions or comments at this point? Okay, Elizabeth, back to you.
All right. Pointer. Thanks. Okay. So now's your chance to work a little bit. So we've already gone through a lot, and we're going to talk about a patient and talk about somebody who is having some trouble and what we might be able to do for her to reduce her risk of falls. So Mrs. Beach is 85. She's living in your assisted living unit. Her daughter lives a long ways away out in Vermont. She has a couple medical problems. She has osteoporosis, congestive heart failure, atrial fibrillation, and arthritis. And she fell last week. She didn't have an injury during her fall, but just having fallen made her more afraid of falling. And so now she's afraid to walk without assistance. She's been staying in her apartment and refusing to go to meals, refusing to go to the exercise classes, refusing to go to appointments. Anyone ever had a resident like this? Never, right? Okay. So she comes to see you in the clinic, and on your evaluation, she's got a blood pressure of 118/80, a pulse of 64. Her blood pressure drops when she stands up, down to 90/60. Her weight is down 10 pounds since she had this fall. She's got some mild ankle edema. She doesn't want to transfer her on her own. Her gait is unsteady even with her walker, and her knees hurt when she walks. And she refuses to even try to walk without some assistance. And she's on these medications. What do you guys want to do for her? And Kathy's going to walk around. We're going to try to catch this on the microphone so that we can make sure we get it videotaped. DC, the Tylenol PM, thank you very much. So get rid of that Tylenol PM, one of the absolute worst offenders. In fact, when I have somebody who gives somebody Tylenol PM, I crack them over the head. And people and there's, oh no, I'm not taking Tylenol PM. Well, what are you taking? Oh, I have this little blue pill that I take before I go to bed at night. But it's not Tylenol PM. I know it's not. And when you finally either get them to bring it in or look at the bottle and admit, yes, it's got diphenhydramine in, because the sleep medications are extremely high risk. Okay, what else do you want to do? Yeah, oh, go ahead. Oh, he's already got one. Yes.
Would we want to up their vitamin D since it's only at 400 and the previous slide said 800?
Uh-huh.
And
I'm going to.
is beneficial.
Okay, good. So her vitamin D level her vitamin D supplementation is probably not adequate, is it? And interestingly, the U.S. Preventive Services Task Force, that organization that does systematic reviews on the evidence for preventive services. They actually did a study of 400 international units and found that it was not effective. So if you're going to supplement, it's got to be better than that. It's got to be at least 800. Yes? Fred?
Is it on? Okay, I would look for orthostatic hypotension.
Yeah.
I
So-
would check the potassium, but she's on a diuretic and
Excellent.
there's no potassium.
So we've got our pharmacist expert right here with the microphone. What else about her medications are worrying you?
The citalopram, maybe a gradual dose reduction.
Fantastic. Yeah, and you know, I think citalopram is a fantastic drug. Don't take it away yet. He's got a couple things. Citalopram is a fabulous drug. For people who are depressed, it works really well. It has a low side effect profile, but it's one of those drugs that if you just leave it on, you could get into trouble. There are some long-term risks for using drugs like citalopram and some of the other antidepressants. So if you start someone on a medication for depression, you know, they're depressed, the first thing you want to do is make sure that their numbers go back to normal, right? Use your PHQ-9 or some other screening tool and make sure that they go back to a non-depressed state. Make sure that it works. And then you want to leave that drug on long enough to ensure that they're not going to have recurrence. Typically that takes about 6 to 9 months. But for most people who have completed an adequate course of an antidepressant, when they've responded, you do want to try tapering back off. Now, there are a few people who, when you try to taper it, will have their depressive symptoms return. And there are some people who require long-term use of antidepressants, but attempting gradual dose reduction with all of these drugs is extremely important. Anything else you want to do about our drug list? The other thing I'd probably be mentioned is the digoxin. Oh, go ahead. Okay, is because for most older people, an every other day dosage of digoxin is the highest dose of that drug you want to give. And for some people, it's just like the citalopram. They might be able to get completely off of digoxin. I have people who come in to see me for the first time. They've been on that drug for 30 years. I'm like, why did your doctor start you on digoxin? And they say, I have no idea, but I've been taking it for 30 years. Okay, let's try gradual dose reduction on this medication. So it doesn't have to just be the psychoactive medications. Yeah, and certainly reducing the antihypertensive medications is going to be very important, isn't it? What's a target blood pressure for somebody who's over age 80 and who doesn't have, like, you know, terrible congestive heart failure or something? What's your target blood pressure in that age group? Do you guys have targets that you work for blood pressure management? 140, is that what I heard you say? Yeah, 140 to 150, actually. You're right. So she's way too low, isn't she? Yeah, even though she's got a little congestive heart failure. But she's dropping to 90, and that's very scary. Okay, so we mentioned the meds, we mentioned the vitamin D. We talked a little, have you talked about exercise yet, Dean? Physical therapy, excellent. What do you want to?
So,
yeah.
Oh, so what I would either do is, if she was one of our residents here, physical therapy might be a little much for her because it's you got to go through the process of getting a prescription, seeing a doctor, and that might just be a little too much. I would probably go down to her room and encourage her to maybe start with a personal trainer, like we have here on campus, just because it's easier, it's more friendly. Physical therapists are mean.
They are.
I knew that was you back there. And, you know, even if she says, well, she doesn't want to walk without a walk, or, you know, she doesn't want to walk without assistance, well, could you, you know, at least maybe encourage her just to, because if she gets up and walks with, even if it's with a walker, she's gaining more benefit than she is just sitting there doing nothing.
Excellent.
So if you get her started with the walker, then maybe you can progress into, you know, a cane or Nordic walking sticks or something else, and then make a gradual change into something else and allow her to build that confidence.
Absolutely. Now let's hear from the physical therapist about what you would say.
Do you need a mic?
I got one.
Okay.
Well, I guess part of it is she also said she had pain.
Right.
So,
We need you both. I know it.
We do. We're an awesome team. But I would evaluate her balance, and I would evaluate her pain, as well as the assistive device, if it's
Good.
properly adjusted or if it's
Yep.
the right assistive device. And because I have a lot of patients that, of everything else we work on, we also work on the confidence. Because if
Yep.
they're fear, then
Yep.
you're not going to get much past that.
Yep, I fully agree. And I love that you guys are a team, because I think that's the right approach to take. And a lot of times I have someone who isn't ready for physical therapy yet, and you've got to be very gentle, and you've got to get in with some of the exercise training to get them started. But they might be walking with a walker that's 6 inches too tall for them. So as soon as they're ready to see a physical therapist and get some of that kind of additional support, I absolutely find it incredibly valuable. And she's got osteoarthritis. So you're going to want to be giving her some exercises that are going to help to reduce her knee pain, increase her quad strength. You know, one of the biggest reasons older women fall is because they don't have enough quad strength. And osteoarthritis of the knees is one of the biggest reasons people don't have enough quad strength. So yeah, Dean.
I have one other suggestion,
Sure.
or just thought. Let's just say that she possibly maybe really likes the water. Ah Chi is a variation of Tai Chi, which is performed in the water.
Yeah.
So getting her in the water might be a good way to boost her confidence up, because it takes out that element, that risk of falling.
Yep.
Because if you fall in the water, you might get your hair wet, but that's about it. So I think maybe even getting her started with maybe going to the pool
Yep.
and doing something in the water to build up that confidence, and then transition.
Yep, I
onto land.
absolutely agree with you. And there's some good thigh strengthening exercises you can do in the water. Now, you do have to be a little bit careful, because having balance in the water doesn't necessarily translate to having balance on land. So, as she starts to regain some confidence, you want to make sure she's also doing some balance training on land. And also, for those of you who are thinking about osteoporosis and fractures and those kinds of things, water exercises don't actually strengthen your bones or protect you against osteoporosis. So if you're only doing exercises in the water, you're going to be at risk for losing bone mass and having increased risk of fractures. So you definitely want to be doing some weight-bearing exercises on land as well. But I totally agree with you. Getting her in the water is going to be really valuable. Reduce her pain, get her doing the strengthening things.
So
Yeah.
while Dean was talking, Michelle was shaking her head yes up and down. So we have agreement on that. Team, Lorna has something to add.
Yes.
Well, her weight is also down 10 pounds, so it
Yes.
seems like she's going to have a nutritionist maybe evaluate
Thank
her.
you very much.
Provide snacks a couple times a day. and
Yep,
have that
absolutely. So through all of this, and a lot of times we're not as careful as we could be about monitoring weight. And her weight might have been starting to go down even before she had this fall. Nutritional imbalance might have been one of the reasons she fell in the first place. So absolutely doing a nutrition assessment, making sure she's getting adequate nutrients, adequate protein, all of those things is going to be incredibly important for someone like this. All right, did we miss anything? Yeah, Laura.
Just in the in the meantime, while we're doing all this, I would work to get staff or a private duty aide in there and assist her to walk as much as possible.
Absolutely. So giving her the assistance to get her back into a normal routine is going to be incredibly important, isn't it?
Seems like you're building a case for a team approach.
I think we've got some fabulous teams already working together here. Yeah, oh yes, please.
How about like massage therapy? You got help to relax for the knee because you have some knees hurt. So there's the circulation for the blood. You know, you got help for them for that.
I wish I could tell you that there were huge randomized trials saying that everyone should have massage therapy. Unfortunately, those don't really exist yet. It hasn't been very well studied in research. I strongly agree with you that doing things like massage therapy to reduce pain, I think acupuncture is actually another fabulous way to help reduce pain so that people will feel more like getting up and doing things and doing those strengthening exercises they need. Today's talk is focused on the things that have strong research evidence behind them, so we haven't included a few of those kinds of things. But I think they're probably a part of a really complete regimen and really having somebody have the optimal quality of life. Yeah, absolutely. Anything else? All right, you guys are good. Let's see. So, the first thing, of course, is the screening for falls. and the timed up and go for somebody like this who's not in a skilled facility. Now, she's already fallen, hasn't she? So she's already kind of past that screen. But just doing the quick get up and go test can help you understand what her gait is like and how much she might need. So her timed up and go is positive. And let's see, I think we've already gone through most of this. Vitamin D supplementation increased to 1,000 to 2,000 a day. You know, Cy didn't mention, some people ask me the question, do I have to check a vitamin D level in everybody? What do you guys think the answer is to that? In her, probably we'd want to, right? Because she is falling. You know, she's got a disease. She's got falls. She hasn't fractured yet, but we're afraid she's going to soon. She's clearly deconditioned. You know, the only absolute reason to check a vitamin D level right now is if you want to start somebody on a bisphosphonate, such as a lendronate. Because if you're starting drugs for osteoporosis, they don't do any good in someone who's vitamin D deficient. So you don't want to give somebody one of those drugs without knowing that their vitamin D level is over 30. However, for the rest of the world, if you just start someone on 2,000 international units daily of vitamin D3, the cholecalciferol, their level's going to get up above 30. It might take a few weeks. For some people, it actually even takes a few months. But you don't actually have to check a level in everyone. I tend towards checking levels. Sometimes if I know their level is 5, I can get them to take their vitamin D more readily than if I haven't checked it and don't know. And sometimes if they're really feeling terrible, they've got fatigue, they've got weakness, they just don't want to get up and moving, and we check a vitamin D level and it's very low, 5 or 7 or 8 or something, I can say, you know what? Let's get your vitamin D going. You're going to feel so much better. Because people who are vitamin D deficient feel terrible. So that's just another way to assess people who are having these chronic, vague weakness, fatigue, those kinds of things. Calcium supplementation, we already talked about. The Tai Chi, work with the activities coordinators. Our last part of this workshop before we break into small groups is going to be around motivational interviewing, so we're still going to talk a little bit about that. Orthostatic blood pressure checks. So this woman is clearly orthostatic and is going to need some follow-up after you've gotten her fluid intake a little better, after you've reduced her blood pressure medications a little bit better. And you know, that should, of course, be transmitted to the provider who's writing those orders. And then safety check, remembering the footwear. I can't tell you how important footwear is, and eyewear too. I've had people who were falling regularly, maybe even once or twice a week, and they went to wearing the correct footwear, no socks, no slippers, always a good pair of walking shoes in the house and out, and they completely stopped falling just from that one intervention. I can't believe how powerful footwear is. Same thing with the glasses. And then I imagine you've already got a lot of home safety techniques in your system. And then, of course, reducing the risky medications, stopping the Tylenol PM, the digoxin, maybe even the citalopram. All right. We're going to stick with the Mrs. Beach theme for just a little bit longer, but I'm going to welcome Glenise and Vicki to come up. We're going to talk a little bit about falls and dementia. Then we're going to talk a little bit about motivational interviewing. And then we're going to give you guys a break, because you've been sitting here a long time, and break into small groups after that. So 2 more presentations. Oh, please.
I actually went to another seminar recently, and I was told that taking omega-3 with the vitamin D actually helps with the inflammation and...
Oh, sure enough. Okay. Say it again. You've got a great question.
I went to a seminar recently, and they said taking omega-3 with vitamin D is more beneficial than just taking vitamin D by itself.
Where's Cy? Can't hurt, okay. I have not, Fred, do you know anything about a specific interaction between vitamin D and omega-3? Yeah, I haven't heard of anything specific about a synergistic effect between the two, but...
they're saying they're both beneficial. The vitamin D helps the bone growth, and they said that the omega-3 kind of helps with inflammation in the joints.
Yes.
So taking the 2 is actually beneficial if you're having pain and you're uncomfortable. That way you get your strength and you kind of take care of the pain part of it.
I completely agree with you. So if you've got somebody who's, got several problems, they've got some osteoarthritis, and it's actually incredibly helpful for heart disease, and possibly is helpful in preventing dementia. So your omega-3 is doing some very important things around keeping people healthy, and the vitamin D is as well. And I think they don't necessarily have anything specific together, but taking them both is fabulous. I fully agree with you.
I just thought
Yeah,
that maybe
good.
if you're going to take vitamin D, you kind of
Take
want to
the
help
omega-3
your
too.
joints too a little.
Yep, I agree with you. You're absolutely right. Good. All right. All you.
Thank you. So Glenise and I are going to tag team and talk a little bit about an important aspect, an important risk factor for falls, and that's dementia. And we want to talk about this and just put a fine point on it and highlight the importance of it, because what we know is that individuals with dementia are 8 times more likely to fall than people who do not have dementia, and that those falls are going to be more serious, more likely to result in mortality, certainly in injury, and that people who have dementia and fall are more likely to fall repeated times. So this is sort of an important area that's not been very much studied, and so what we'd like to do is just tell you a little bit about what we do know, and maybe present a few issues about why we don't know more, and also to talk with you, because a lot of the research now is being sort of developed just from a trial and error, just like you probably have attempted in your facility. The reason that people fall are all the same thing with dementia, are all the same things that we've talked about before. So that doesn't stop all the risk factors from operating to produce risk in individuals who have dementia. But in addition to that, and well, before I go on, I'd like to make a special point of individuals who do have dementia are still more likely to fall for reasons of like orthostatic hypotension, and also have a higher incidence of a 12-month fall risk. So those two risk factors that are likely to predict any older adult in your facility for falling are even more likely to predict that older adults with dementia will fall. Also, the severity of the dementia is somewhat of a predictor. The idea is that the more impaired, the more cognitively impaired a resident is, the more likely they are to fall. But it is true, too, that people with MCI or mild cognitive impairment, very low levels of cognitive impairment are still a fall risk, because the same factors that begin to operate and make cognitive impairment a risk factor are also operating very early in the disease, which tells us that if we are working with MCI, for instance, in the community, it's a great idea to test early for fall risk, and especially for instability in gait, and then do something about that to help exercises, for instance, for balance and strength training to prevent them from falling later. In addition to the factors that you see up here and all the factors that you regularly would have with risk factor, there are 2 or 3 additional reasons why people would fall that provide us with some information about risk factors and things that we should be looking for. One of those things in particular are what the effects of the cognitive deficit itself on things, for instance, such as gait stability. One of the more exciting new variables that we're seeing in the literature now has to do with attention as a predictor of falls. And the way that that would look, especially when it's combined with a lack of judgment or executive function in these individuals, would be that let's say you take an average person, an average older adult that has a pretty high disability level. That person may take 100% of their attention just to walk properly and to be able to attend to the things that they would need to attend to, like, for instance, obstacle hazards or the speed of their gait, so that their gait doesn't begin to outpace their ability to and their strength and their coordination in order to follow through with that. And so when you have a cognitive impairment, it would make sense that you have less cognitive reserve in order to walk properly and to step properly and to avoid obstacles. Walking and talking are two things that draw on your attention as you ambulate. And so if a person doesn't have good judgment, they may not know how to balance that, or may not understand that their gait is even too fast, as slow as it might be, may be too fast to be able to negotiate a proper gait speed, for instance, or a proper gait, having your gait be somewhat consistent. And those are both high predictors of falls, regardless of whether you have dementia or not, but it's certainly more of a factor in people who have this have dementing illnesses. Another factor I think that is important for us to consider is the behavioral disturbances that you're more likely to have with dementia patients. So the behavioral disorders that occur as a result of dementing illnesses, which may be everything from agitation, behavioral disturbances, vocal or physical, or let's say paranoia, hyperactive behaviors. Those are all predictive of falls and have been found to actually precede falls in people who have dementing illnesses. Now, I think it's important to put a fine point also on the fact that this is also a population that's more likely to experience delirium. And when that's undetected, then that's also a contributor. So there have been some interesting studies that have demonstrated success in doing even more careful delirium screens when the fall risk is involved, and immediately preceding and then immediately after, to see if that's an issue. The other thing that I think is important to point out is that the kinds of research that we've been doing hasn't carefully identified or separated out or analyzed separately the effects of the different dementing illnesses. So there's some exciting research that's been very helpful in identifying if all of the dementing illnesses have an equal effect on, for instance, gait, balance, and falls, or if there's maybe some dementing illnesses that are more risk prone, that present a higher risk than others. And what it's told us is that yes, indeed, that's the case. There is a higher risk for people, for instance, with Lewy body dementia or with Parkinson's type symptoms, much more so than Alzheimer's disease, for instance, or vascular dementia. So that's worth beginning to kind of look at the differences in the physical disability, the kinds of gait disturbances that might occur in individual cases of dementia, and attending to those in particular. It's a little bit different than the kinds of approach you would take with, for instance, an individual who is older but has some kinds of physical problems and would be a fall risk. And so you could go along a continuum of identifying and screening and providing strength training and providing some kinds of exercises that focus on balance, for instance. With dementia patients, you have to be, I think, much more sensitive to the particular kinds of gait disturbances that are being produced by the dementing illness, and to individualize a lot more. Not all individuals with dementia, let's say Parkinson's or Lewy body, would be as amenable just to a cookie cutter sort of one kind of exercise program fits all, and you'd really want to be much more tuned into the safety of the exercise program that you start than maybe other groups. This is sort of an interesting slide because it talks a little bit about when dementia patients are most likely to fall, and of course nighttime is a particularly high risk time. And also during maybe that period of time that we think of as sundowning. So we might want to make ourselves a little more sensitive to watching during those times, make sure we don't understaff at night, Most falls occur when you're walking, standing, or sitting and getting up and down, but also going to the toilet and rising, getting up and getting down, and maybe some of that's confounded by the fact that it's also occurring at night, so that's an important risk factor. So I just wanted to add one thing before I hand the mic over to Glenise, and it's that it's just to say that it is true that activity, high levels of activity and exercise are preventative for fall risk. But once again, what we have to sort of look at with regard to individuals with dementia is is whether or not they have the kinds of gait that would differences in gait that we might want to individualize and make special arrangements or individualize. One thing I really love about your dementia unit is that they do seem to be a high touch kind of unit, and that seems to be their philosophy. And the nice thing about that is it allows you to really individualize how you work with patients and make it a little bit safer, and do your adaptations for your exercises, and then, but not to restrict their activity. I think that's probably true of almost any group. So, Glenise.
Great. So you guys hanging in there? Okay. So dementia is a brain disease. Hence, there are certainly adaptations that are going to be made now that we're talking about dementia. And so some of the studies have been really some strong systematic reviews looking at what's different, some of the characteristics we just looked at. Not so much as far as clinical trials for doing interventions to prevent falls. So some of this is really sort of clinically based suggestions and strategies we're going to talk about. I also know that we're going to get some strategies from all of you. But I'm feeling like you guys need to do a little activity here because you're starting to look a little drifty. Okay, so this is just a reminder that I sometimes do with my students I teach here at OHSU School of Nursing, is everybody stand up. Okay, and then I want everyone to check your peripheral view. So where can you see your fingers moving? Okay. Okay. Everybody find your fingers? Okay, very good. Now bring it into about here. Okay. Here. Okay. So one of the changes with dementia is that you do get your peripheral vision cut down a little bit. Okay. What was some of your what did you find out from that exercise? Fear. A little bit scary walking around when I can't see things. Anything else? You have no sense of awareness. Yeah, sense of awareness, and I know the table's here and I walked into it. Okay, so awareness, a little bit of fear. It's a little bit scarier to go out places. Okay. Right. And the other thing is that when people are right by you, sometimes you don't see them till they're in front of you, and they can just appear. Okay? So it's people who work with people with dementia can sometimes see this, and it's so just a reminder that there actually are brain changes that are there for affecting us. Now, everybody, put your hands up like you got binoculars on. Okay, go for another walk. But be careful. Okay. Okay. Okay, how'd you guys do with that? Yeah, so you kind of, again, sort of, it just accentuated that you can sort of bump into people, random people. People can come up into your peripheral vision and actually surprise you. So there's some support for that in the later stages of dementia. It's a progressive brain disease. It's going through, for example, an Alzheimer's disease. And it gets to your visual centers in the later parts of the illness. And so you're going to actually end up in the later stages having even more restricted view. So this whole idea of, gee, do you think they fall more often? Yeah, makes sense. And then the gait disturbances that we just talked about, and people have, of course, seen the shuffling gait of your person with Parkinson's, and then you've seen the more sort of almost a broad base sometime with some of the people with dementia. So all those gait changes all make sense that we're going to be even at higher risks when you're talking about people with dementia. Okay, you guys were very good. You can sit down. Okay. So we're going to do the same things. We have the same risk factors in addition to these brain change, gait change, sensory changes that we're adding to it. But the same things are also happening. Strength is going down. Balance issues just related to age-related changes are happening. So we're going to do all the things that my colleagues just told us about. We're going to do all the same things. Okay? But in addition, we need to do some anticipation and accommodation for people who have the dementia. And one other piece that there was a little bit of research on was individuals who have depression, so dementia, and they also have depression. Okay? When the depression is treated, the fall risk goes down. Why would that be so? Ideas? Potentially, there's just basically, dementia or depression takes down our sort of initiative and motivation, and activity levels can certainly be down. Isolation goes way up. So for probably a combination of reasons, when people actually were treated for their mood disorder, they actually had a decrease in their fall risk, which I think is a great finding. Okay, and then so then anticipation of needs comes into all of us as caregivers, which is what you guys do with people with dementia all day long, every day. And this is just keeping in mind that part of what you're doing also is to protect folks from falls. So we're going to have exercises. We have heard many great exercise interventions that are happening here, as well as on the memory care unit. Really think about incontinence and the slips and trips related to getting up and rushing to a bathroom. Thinking about getting your sleep patterns right, which we do for many reasons, and another reason is that if people are well rested, they're less likely to fall. And managing pain. So someone was great about our case study here in recognizing pain, and we all know that folks with dementia are generally not often able to verbalize to us, so sometimes it's going to be medicating for pain in anticipation for it. Okay, and you guys also gave great about 10-pound weight loss, and if this person has dementia, we're going to have to be providing snacks, bringing in food, things that they like, figure it out so that they were actually getting their calorie count up. And same thing at nighttime. We're just trying to anticipate so that we can prevent the fall from even happening in the first place. Okay. So Tylenol, not Tylenol PM, but plain Tylenol can be provided at night again, just to try to get comfort and a restful night so they're not getting up and being restless. And the lighting, okay, so think about, we've got restricted vision, so the night lights are real important to have people, when they are getting up at night, that they can see obstructions on their way to the bathroom, and try and limit, that people are getting a good night's of sleep, but that not kind of oversleeping and getting sort of groggy on us. Okay. And same kind of approaches to environmental design. Added to that is actually safety rounds, so removing hazards. Do you guys do safety rounds on your units? Okay. A lot of as high as I don't know. One of the studies, as high as 70% of falls were in some way connected with, it was just a hazard in the way. And so that, doing that, very powerful for protecting your client, or for your patients. And the other thing that I do not have any research on this, but I still think it's a good idea, is to do mood and behavioral rounds, okay? Because, we find that people with behavioral issues are more likely to fall. So actually, when you're doing your morning rounds and you're saying, oh, so-and-so was up last night, they were restless, agitated, part of what you're doing is actually protecting falls when you're identifying people with behavior issues, identifying people with a starting of depression symptoms, because those, when those go down, falls go down. And that you guys have some way to communicate that there's someone at risk for fall on your unit. And then training. So staff trainings is, when people are trained in what to look for, like we're doing today. There's some with a dementia client or dementia population specific that showed like a 50% decrease in the number of falls in patients that were fallers before. Okay, so you can make a big impact on your units simply by being trained and then taking what you learn back to your people that you work with. Okay, and then the exercise. So indeed, exercise with people with dementia has been shown to be helpful. The most helpful so far is with the mild for the Tai Chi. What would be some concerns about Tai Chi and dementia? Yeah, okay. Oh, my question was, what would be different with dementia and thinking about Tai Chi? Tai Chi's been found to be very effective, but now, what are we going to do differently with someone with dementia? Okay, so we're concerned. Yeah, we're probably concerned about visual field cuts, so we're also concerned about, you know, that the balance may be impacted. Okay, so touching, and I'm sorry I did miss what you said. Comprehension. Okay, so right, hallmark of dementia is a memory issue. Okay, so you're going to have to probably be with them, and they're not going to learn the routine and then do the routine, you know, 3 and 4 times a week, which we, of course, you know, folks without cognitive impairment are going to be fine at. So we're going to have to actually probably be in the room and mirroring what they do. There's some study around actually doing some sort of hands-on, actually, you know, moving the hands with them versus even mirroring it. I mean, sometimes that's what's going to be effective.
Have you guys seen the sticky hands approach for Tai Chi and dementia? Yeah, where you put your hands, like, so if Glenise, if I'm the caregiver and she's the dementia patient, I might actually do fruit picking with her so that we're doing it together. And it's a really lovely way to engage someone who's a little bit more debilitated in these movements. And also it's a really nice touch thing. So, you know, people with dementia do need a lot of touch to maintain security. And so the sticky hands approach is a really nice way to do that for patients with dementia.
Great. Other comments about Tai Chi or exercise and dementia? So I think you guys did nice little comments about that. The onus falls on us to keep it, to keep it safe and appropriate. And you know, as we know, our judgment gets impaired with dementia. So the impulsiveness of dementia is really having you know, someone present and able to either mirror or sticky hand, or and that we're assessing that they're actually safe to do what we want them to do. And there have been studies specific with Parkinson's, for example, that have shown some improvement in the mobility and gait, so specific. There's other exercises besides Tai Chi that have been studied with individuals with Alzheimer's disease, for example, and that was very strength and balance based, and they did show improvement, and they did have a decrease in falls. So you can have sort of disease-specific, if you will, illness-specific approaches to the exercise that can be very effective. Okay, and burning questions at this point. You guys want to anything? Okay, we're tiring you out. I know. Hang in there. Okay, wait a minute.
One of the things that I'm thinking a lot about with environment, which I realize this sort of was the foundation for a lot of where we are right now, but so I'm kind of interjecting this at an odd point. But a lot of our residents, I notice, they struggle with their ADLs in the sense of, you know, putting on their undergarments, you know, and or if they have to change their pads, or if they need to bend down to put on their, you know, their stockings, their compression hose, their shoes. So I'm really seeing where just a lot of this strength and flexibility and balance. I think there's a lot of unreported falls in these areas of ADLs. And I think these things with encouraging strength, flexibility, and balance, we might see a big change in a lot of those falls that are happening in just performing ADLs. So.
I think that's a great point to have in addition to that. Okay. Right.
Yeah, so I agree with you on that. And there's starting to be a little bit of evidence around the Tai Chi because it does improve flexibility and it does improve range of motion. So the fact that you're doing some of those exercises with the person is going to increase their flexibility and allow them to do things like bend over to put their shoes on, or bend over to get their pants, their foot into a pants leg, things like that. The research is just starting in this area. You know, it's not there yet, but I completely agree with you that a lot of falls happen during those ADLs, and that some of the Tai Chi movements are very beneficial for getting people more able to do those ADL activities. So you're absolutely right about that.
Yep.
I think Laura mentioned something when we were chatting with her earlier about using, on the flip side of using those same ADLs to encourage exercise. So for instance, being able to get range of motion with your patients as you work with them by having them reach for things and pick up things from the floor and to move in ways that they probably would be resistive otherwise, because that's the other feature of dementia, is we don't often get an opportunity to decide when they will do Tai Chi or exercise or just about anything. So if you can engage them in everyday activities in a way that's much more guided, you can also get some exercise in there.
Great. Oh, one more.
I'm sorry. That's why I have my own microphone. When we're in the gym, just like our visual or our point, you know, with all the exercises that we do relate to ADLs. You know, like we make sure that when we're doing sit to stands, we try to use a chair that's the height that they would normally correctly sit in, you know, versus a chair that's too low or too high. You know, a lot of our clients that come in, a lot of the residents that come in, you know, with shoulder injuries or leg injuries or whatever they may be, our main goal is to get them back into doing their ADL safely and more efficiently. Like one person took a year after rotator cuff surgery, but she was thrilled that now she's finally able to get her own cup of coffee in the morning because it was on the second shelf and she can never get it. But you know, so everything we do, you know, has that ADL in mind, because I mean, you're not just coming to the gym to get stronger, or I mean, no one's coming to the gym to get their bikini bodies or their six packs or anything like that. I mean, what we're doing here is we're trying to make people's life safer and, you know, to prolong any sort of decline in the ADLs.
Yep. And so really, it's function based, and doesn't that make sense?
Totally
So
function based.
Find their goal and whatever their goal is, and then work to the function of that. Great. And I will introduce Kathy.
Segue. Thank you for that story, because we're now going to switch gears a little bit and talk about how do you motivate somebody to exercise more or to engage in Tai Chi or something of that sort. And I know none of you exactly waved your hands that you knew about motivational interviewing when we asked the question at the front end of this presentation. I was in your same shoes about 6 years ago when we changed our curriculum at OHSU School of Nursing, both in Ashland and in Portland and our other locations. And we started introducing the concept of motivational interviewing in our health promotion class. And so there's bad news and there's good news. Number one, the bad news is that this is really the good news. You really can't motivate somebody to change. But the good news is that with a tool like motivational interviewing, also known as MI, not to be confused with myocardial infarction, that you have a way to elicit the motivation from them. And Dean just gave a great example of somebody who wanted to pour her own cup of coffee. That was her motivation for continuing to do the exercises that seemed like perhaps at some point during that year she was getting nowhere. So I will tell you this, motivational interviewing is a developmental skill. It's not something we're all born to do, and it takes practice. So we're just introducing some highlights today in terms of a way to get started with it, and then you can advance as you work with more and more patients in terms of making change. I will also just say it's probably not a skill that is typically used with dementia patients, depending upon where they are in their disease process, but it might be. So you might find a way to do that. So we've kind of made a switch back to perhaps the less demented patient. But I think this statement at the bottom of this slide is really, really helpful in terms of the high points of what MI is all about. It's collaborative. In other words, it's not me telling you what to do. We're going to work on this together. Hang on just a second. It's also person-centered, or if I may make that more specific, patient-centered. It's what they want to do. Form of guiding, not telling, to elicit and strengthen their motivation for change. Turn it on. Okay, there you go.
It is on. One thing that we also do, which I'm really, really glad to see that up there, it's kind of that confidence that we're doing it right, is whenever we have a new resident or a resident who's been here for a while, whenever someone is coming to us to engage, whether it's information about a class or it's for a personal trainer or a water program or whatever it be, it's not like us going out to them, but them coming to us. Our first thing before we prescribe or suggest anything is we ask all of our residents, what are your goals? Why are you here? Why did you come here? Why did you come to see me? And we find out what their goals are, what they want to accomplish, and why it is that they want to do it. And then that's how we base kind of what direction we send them based on that. But every time they're in the fitness room, we usually start with about a 15-minute, 20-minute conversation about why they're here, what are their goals.
Great, and I think you're in a very specific area in the manor here, in the manor scheme of things. Some people might be on a unit where you just want somebody to actually participate in getting themselves dressed or something of that sort, and so eliciting what their goals are relative to their independence may be a little bit more difficult than why should I exercise. But you're going to see a couple of examples here. So I think we've already talked about the fact that this is something where you're actually gaining their motivation for making a change in their life. And this has been done in lots and lots of trials around particularly things like smoking cessation, alcohol management, those kinds of things, sort of big major life issues. But it has been very, very well tested and tried. Rolnick is kind of the guru or the father of motivational interviewing, and a lot of books and articles have been written by Dr. Rolnick. But it is something that any professional can use. It does require practice, as I mentioned, but it also works best if you are able to identify a health gap or a behavior that somebody wants to change. And in this case, risk of falls for somebody who's afraid of falling might just well be that behavior that needs to be addressed through exercise or one of the other interventions we've talked about. And so you're eliciting, in this situation, you're eliciting their motivation for addressing this risk for falling. It is, I think, well, let me just say this. When I went to school, I was taught patient teaching principles, and patient teaching was much more about telling people what they need to do, because don't you know I'm the expert. This is not so much about that, because in fact it's a recognition that they are the experts about their own bodies and about their own needs, and we're working with them to help them make the changes that they want to make. So I love these verbs in the second bullet, the idea of guiding rather than directing, dancing rather than wrestling. That's a very physical metaphor, isn't it? And listening as much as telling. And, we do have special knowledge as healthcare providers. We do have special knowledge, and we have so much that we could share with them and that we could tell them. But it is certainly something that's just a little different approach, and we'll see how that works out here in just a moment. But the idea behind it is this idea of honoring patient autonomy. And I don't know about you, but as I'm approaching older age, I don't want you at the manor, if I were to move in here, I don't want you telling me what I should do, right? Who of us does, for goodness sake? I think we all want to be autonomous, and that goes for older adults as well as for as well as for younger folks. So that is really a key element in motivational interviewing. You can give some information, you can advise, but not until you find out what their motivation is. So here is the rule, if you will. And actually, let me say one more thing back here. I don't know about you, but I have, we went around the room here, I would be willing to bet money that almost every one of us thinks we should be exercising a little bit more. Is that a safe thing to say? Yeah. So how do you know when somebody's really ready to do that? Well, I've been talking about doing extra strength training for at least the last 4 years. So until I have a sleeveless outfit that I think I'd like to wear to a special event, or I see a really unflattering photograph of myself, or I can't pick up my grandchild and walk 10 feet without getting short of breath, or one of those kinds of things, or be able to pour my own coffee, if I can go back to that. I may never get around to making that change in terms of adding more strength training to my regimen. Now, I'm pretty good about doing the cardiovascular stuff. I do that pretty religiously, but I need to do more strength training. So you get the idea that their readiness is key. And so finding how ready somebody is to make a change does involve figuring out their motivation. If my kid's getting married next summer and I want to wear this special dress, that might just be what it takes. If I know that I want to go to my grandchild's soccer game, but I can't walk to the bleachers, that may be just something that would motivate me. So you see what I'm saying in terms of finding out what motivates people. So here are some rules, and it's handily put together into an acronym. Resist the writing reflex. You know, we do this with our children, right? We say, don't do that. I need you to do this in order to stay safe. Resist that. These are not your children, right? Understand your patient motivation. We've already talked about that quite a bit. Listening to your patient, and I mean really listening, and you're going to see some terrific examples here of real honest-to-goodness listening, where you're really paying attention and you're not trying to jump in with the answer, and you're really trying to understand where they're coming from. Then empowering your patient, and these are hard things. I struggle with these things even now when I'm working with patients. The idea is you want to empower your patient, and these first three things, RUL, will help your patient to get to empowerment. So what we're hoping to get to is hearing the patient make some move toward change. So in the example that I gave you about doing more strength training, what you might hear is, Kathy, what would that look like for you? Well, if I were going to do more strength training, I'd need to do it on Wednesday because I'm busy every other day of the week. Well, how do you think that might work for you? Well, I guess I could change something around on Wednesday afternoon that I do and go to the gym that day. That's an example of change talk, where you begin to hear the person talk about the potential for change. I guess I could get a ride with someone. Well, I could measure the coffee into the pot for our patient who wanted to make and pour her own coffee. Something that moves them toward change, and then that's what you, the motivational interviewer, pick up on and begin to explore with them a little bit. Patients know themselves better than you do or than I do, and so helping them to understand how they can get to their preferred change behavior is really what this is all about. So let's see a couple of examples. In example number one, this is pretty straightforward example of our very own Elizabeth, who is interviewing a patient who has, I don't know if she had a stroke or, she had a stroke, and she is afraid of falling. She's in rehab right now, so she's afraid of falling. And what I want you to watch for in this is how Elizabeth is expressing empathy toward the patient and getting at what the patient's goals are through her questioning and listening, and then providing some recommendations that the patient can take or leave. And I have to say, one of the other little pieces of MI is that the outcome of whatever the patient decides, you have to kind of let go of that. And that can be hard for us. We want what we think is best for the patient, but in this particular strategy, we're not invested in the outcome that they choose, and that's the tricky part. So watch Elizabeth in action here, and then we'll have another little example that goes just a little different direction in terms of eliciting more change talk.
But what are your goals for the long term?
I want to go home.
Oh, of course, of course. And what are the things that you'd like to be able to do once you get home?
Everything. I want to play with my dog. I miss my dog. I want to cook for myself. I'm a very independent person, and I want to do things for myself.
Yeah, yeah. And so that's a very important goal, to be able to get back home, to be able to get back to your independence. Have you thought about what it might take to get there?
I guess the rehab.
Yeah, you're absolutely right. And it's also going to be very important that once you're home, you're able to continue on a regular activity program. Have you thought about what that might look like?
Not really.
Not really? Okay.
Yeah.
Well, have you ever heard of something called Tai Chi? Is that a familiar term to you?
Yeah.
You've heard of it?
Oh, I have.
Okay.
I have a friend who does it, and she just raves about it. She loves it.
Well, you know, Tai Chi is one of the best ways to get your balance back after you've had something like a stroke. And it's also really good for preventing falls. And if you want to be home and you want to be doing the things you want to do and going for walks with your dog, it's very important to make sure that you don't fall, because that could cause more problems down the road.
Absolutely. I do not want to fall,
Yeah.
for sure.
So what do you think about Tai Chi? Is that something you think you might be able to try sometime?
Well, I hadn't really thought about it, but yeah, I guess.
So you heard Elizabeth empathize, you heard her explore some of the issues around what this woman's goals were. Her name is Mrs. Smith, I believe, of course, and begin to pick up on those goals. She wants to go home. She wants to be able to walk her dog. What's that going to take? So in some ways, Elizabeth was beginning to help the patient explore what the gap is between where she is right now and what she needs, where she needs to be in order to go home. In this visit with Mrs. Smith, you're going to see Terry, one of our other nurse faculty at OHSU Portland, elicit a little bit more change talk. In other words, get at that issue of how to address the gap between where she is right now, what she's doing, and she also explores this idea of fear of falling a little bit more. There's another part of MI, motivational interviewing, called another acronym called DARN, where you explore what they want, what their hope, what their wish is, what do they think they could do, what can they do right now, why would they make this change, what would be some of the benefits and risks, and really explore that with them, and then determine how important it is to them. I like the idea of, again, listen. I would ask you to listen for two things. Number one, Terry uses a part of a MI strategy called summarizing, where she really is demonstrating that she has listened and that she is saying back to the person what she heard her say in an attempt to really help that person clarify what their goal is. That's a strategy within MI, but it's a simple enough strategy that we can all do. It helps us to pay attention, quite honestly, if you choose to summarize what the patient has said to you at the end of the time that they've been talking to you. But more importantly, it helps that patient to hear their own words back and to begin to think about what change they might be able to do and how they see that change. So listen to Terry and Mrs. Smith. This little segment's just a little bit longer. Not much. Oops, wait a minute. Sorry. You'll hear these things: honoring patient autonomy, patient-centered problem solving, and then this idea of eliciting change talk. This idea of high quality listening, some people will say, well, you know, it takes too much time. I just don't have enough time to listen that carefully. Honestly, you would be surprised at the little bit of time that it takes to listen intently, to do a little bit of summarizing, and then see where it takes you. I think you'll see the quality of the interaction here in terms of how that works. So here we go.
So you haven't seen the results that you want yet, but
Right.
because Dr. Fields has recommended it and your friend has,
Yeah.
and it sounds like you liked the instructor,
Yeah, I do.
Sounds like you'd like to try and give it another chance.
Yeah, I would.
So what has to happen in order for you to get to Tai Chi again?
Well, I'd have to make the arrangements again. That was a little complicated. And I'd have to get my head straight about feeling self-conscious, because I know that nobody's really looking at me, but I have to convince myself.
Yeah.
Yeah. And the arrangements are a little complicated.
So how confident are you on a scale of 1 to 10, with 1 being not at all confident and 10 being very confident that you can make the arrangements in order to get to Tai
That
Chi?
I can make the arrangements? 5.
5.
Yeah.
So
I mean, I know I can, but it's really difficult.
what is it that makes it a 5 instead of a 1? No confidence.
That I'm doing it by myself. And I would really feel, if I could have like if somebody could help me do it. My daughter can't visit that often, and yeah.
So in order for you to feel more confident, you would like some help in making those arrangements?
I would. I would.
And is that something that your daughter can do for you?
Well, she could, but I'd have to wait at least a week.
Okay. So is that something that you'd like us to help you with?
I would. Yeah. Is that possible?
Sure, we can make those arrangements.
So what did you hear Terry do in the middle of that interview that helped to get at where or how stuck this woman might be in terms of moving forward with her commitment to Tai Chi? Okay. A scale of 1 to 10. That's a great way to find out just how ready somebody is or how ready they feel. And then so she asked her on a scale of 1 to 10, with 10 being absolute confidence that you could make the arrangements and 1 being not confident at all. And she said she was at a 5. Well, when it came to actually exploring that, and one way to explore that is to say, well, what makes you a 5 instead of a 1? Or a 5 instead of a 10. That's a great way to elicit some change talk. And so, again, this is something that is a developmental skill. It's something that we all are, those of us who have been exposed to it before, are still practicing. But we'd like to give you a little opportunity to practice with that today, if that's something your small group would like to practice. So that leads us right to the small group work, and we're going to have a little bit of a break between 2:15 and 2:30 and then reconvene. So don't get up yet, please, because I want to tell you what we're going to do at our small groups. We are going to, the main thing that we would like to accomplish in the small groups is for your team to identify 2 or 3 interventions that we've presented today, whether it's vitamin D supplementation, environmental challenges, those kinds of things. We'd like you to identify 2 or 3 interventions in your team that you would like to start or begin or initiate. Some of them you might already be doing, like particularly on the nursing home side, the MDS, I know that you do the initial screening, but we'd like to help you get a couple of these things done to see if we can realize a drop in falls at your facility and on your team. So we also can do some motivational interviewing practice if you'd like to do that. And we want you we want to help you develop your own fall prevention plan in your team. And so your team will be together. You've all been assigned to a team 1 through 4, I believe. And then we'll convene at 2:30, and then we'll return to work in the small groups until 3:45, and then come back all together for our wrap-up. And we need you to come back for the wrap-up, and so I would really ask that you work within your teams to work quickly for an hour and 15 minutes. And what have we decided in terms of the where?
I think, unless anyone feels really differently, what we'll do is we'll just kind of push 2 sets of tables into the back corners and 2 sets of tables into the front corners, and we'll just all stay in this room so that there will be 1 team in each in each corner and work together, and it can get noisy, and that's okay. We'll just, ignore other teams, but have fun together. And that way at 3:45, we'll just kind of all be here and be able to come back to the big group session. Does that sound reasonable? Yep. Okay.
So shall we say 1, 2, I noticed a lot of my 2 team members over here. 1, 2, 3, 4.
Okay.
Does that work? And then here, we can leave this up on the board. Here are the goals. We want to leave with a concrete plan for steps to reduce falls for the next 12 months. We're going to provide you with lots of materials to help you be successful. And 1 or 2 of us are going to sit in and help develop some outcomes that you feel comfortable attaining and working on for the next year. And then we'll be coming back to see how things went for you. And we're excited to work with you. We've just had a great day so far. So take a good break, come back. 1, 2, 3, 4. Okay? Thanks.